everybody. My name is Natalie Yeadon. I'm the CEO and co-founder with Impetus Digital. At Impetus Digital, we built some of the best-in-class asynchronous and synchronous virtual collaboration and communication tools. We've helped life science companies from across the globe over the past 13 years, help them with everything from virtualizing their advisory boards, to creating online medical education events, helping them with virtual publications, investigator meetings, and everything else that you can imagine. And since the launch of our award-winning Insight Events platform, we've been also helping pharma companies with hackathons, global MSLE huddles, conferences, sales training, and all sorts of other types of larger events. But more importantly at Impetus, we really believe that everything starts with a conversation. And from these big, hairy, audacious conversations with some of the leading edge thinkers, digital provocateurs, and the healthcare leaders, is we can all work to collectively and positively disrupt healthcare. So I'm really thrilled to having one of these thought leaders at the table with me today. This is actually Dr. Zayna Khayat. She's actually a future strategist with SE Health. It's actually formerly called St. Elizabeth Healthcare. This is actually a health and social impact enterprise with a major focus on creating a better future for aging adults in their homes and in their communities. Zayna is faculty of Singularity University's Exponential Medicine stream and is adjunct faculty in the health sector strategy stream at the Rotman School of Management at the University of Toronto. She was previously the lead of health system innovation at Mars Discovery District, a health innovation hub that's based in Toronto, Canada. In 2017, she was seconded to the Reshape Innovation Center at Radboud University Medical Center in the Netherlands. Zayna completed her PhD in diabetes research from the University of Toronto in 2001 and followed by a career in strategic consulting, including as a principal in the healthcare practice of the Boston Consulting Group, or the BCG. Welcome, Zayna. So happy to have you on the show today.
Thanks for having me.
Outstanding. I'm really thrilled to have seen such a colorful and really immense background that you have, going from science and, through your journal, through academia, and then getting into strategic consulting, and now landing in a place of considered as a futures strategist. Tell us a little bit about how you've navigated and planned this really interesting career trajectory.
Yeah, of course, it's only hindsight that there starts to be a pattern of different career choices. I'm sure your listeners can relate. So if I had to sum it all up, even going back to high school, if not earlier, the constant thread has been, really, really messy, intractable problem that I have a path to impact with, and with a team that I love. And so whenever those three were aligned, then that's kind of where I ended up. And now I think I'm really at the pinnacle of it at SE Health, because, the future of aging and aging in place, and, keeping our healthcare system protected so there's enough to go around, is a massive intractable challenge, and COVID made it worse. I get to work on paths to impact that at scale through the futures team that I lead. And then my team is amazing. So the three together has been, I think I finally found the recipe that combines the three together.
That's a beautiful thing. I would love to dig into this because you absolutely said it right on the spot, Zayna. This is so timely. COVID has exacerbated or accelerated a problem that has been existing for years. We're also in a place where, let's be really frank, there's a bolus of people, again, the baby boomers, however you want to term the generation, who are going to be entering into that seniors marketplace, if you will. So this is an inevitability. It's an externality that we're all going to have to deal with. And so I love the fact that SE Health is really digging into this. So maybe we can spend a couple of minutes, Zayna, and just talk a little bit about what the company's mission and vision, and really what kind of work you're doing.
So the organization is 112 years young, started by 4 midwives in Northern Ontario. And now we're some 10,000 people across Canada and internationally now. And, structured as a nonprofit, but also a social enterprise. That means any, margins we might generate from our business of caring, which is already amazing mission work. We see some 20,000 people every day in their homes and deliver care to them. But we then reinvest that any proceeds to impact platforms, and I'm one of the impact platforms, and there's many others. So across all of that, both kind of the business of caring platform and the social impact platform of SE Health, we're in for sure home care across Canada, seniors living, so retirement homes and nursing homes. We have a portfolio there. The third big business line is transitions, so hospital to home, prehab, post-hospital surgery. So more and more hospitals are discharging people the same day or a lot earlier and completing the home hospital. So the hospital care at home. We have a whole education platform, so career colleges. We train health workers, community health workers, including in First Nations communities. And then our fifth business line is our Eliz caregiver platform. So that's for you and me who are taking care of parents, and products and services for the family caregiver. And so the futures team, looks at and explores next practices, next business models, next opportunities in those spaces that surround basically a common thread of aging in place, aging on your own terms, and healing in the home of your choice.
Yes, it sounds absolutely fantastic. Now, like you said, there's multiple different lines, and you're really more of the futurist, sort of the strategist, kind of preparing and planning for the next steps and things that people might actually see on the precipice or may not be ready, or maybe some people may not even know that this is approaching. So let's actually just talk about some of the core issues associated with aging. What is currently, if you were to summarize some of the problem statements of what we are about to start to encounter?
I mean, I don't know if problem statement and issue is the language I would use, to be honest, to frame this. And, we're not fluffy and optimistic like, it's amazing opportunity, but it's just a major change in the composition of our population as a species that we have really never seen in the history of our species, right? So to have this many people alive over 65, it's never occurred. And that number will only grow. And so just the social norms, the policies, the products, the services have yet to be developed to reflect 1 in 5 of us being over 65. It's just never happened. So I think that's what we set out to do in the book we wrote, The Future of Aging, is to look at, okay, well, where is that going to be confronted the most? And to me, honestly, I see this mostly as opportunity versus risk or, some loss for really both the incumbents who are maybe already touching people in this space, but more importantly for newcomers who now have maybe some new capabilities to bring that the incumbents, are too blindsided. And I think they're going to bring some very new products and services and policies. So, in general, we can get into the book a little bit more, but, there's a whole set of themes around housing and community and where people live and how they live. That, again, very little of the models of housing and community we have today make any sense for an aging society.
Yeah, so maybe we can explore that. I mean, Zayna, you and I both live in Ontario, and we know that this has exploded recently since COVID, and we've had multiple shifts in leaders in long-term care and what's been going on and what's not. And there's all kinds of controversies and debacles and things that have happened. So if we were just to take a look at that specifically about senior living, what is happening in those situations, what are some of the things that, you have actually predicted or are making recommendations for in terms of people who may not be living at home, but are living in these senior locations? What are some of the things that we could foresee happening or that we could potentially fix?
Well, I mean, I think we have to start at the first principles, is not accept that those people need to be there and they actually don't want to be there. The majority, of course, there's always a segment that is a perfect opportunity and pathway for, but that's a very small percent. I'm talking 3%. So first, let's dispel the assumption that we need these buildings. And so then if what was left was the people who want to be there and need to be there, we actually might not have any of the issues we had. And that's kind of what happened in other countries that didn't take a default pathway of warehousing older adults, when their medical needs or sociological needs get complex. So our thesis is there are beds everywhere. It's called the home and the community. And let's create experiences that allow people to age and heal in the place of their choice. And if we do that, I don't think we'd have the kind of problems we do. I personally don't like to get into the whole long-term care home discussion because I think it's not the right discussion. It assumes we still need this stuff, and we actually don't. And we actually can't afford it anyway, and nobody wants to go there. So I think that's what we looked on, is all these new models of living and community and housing and new business models for paying for this stuff, new market vehicles that just are yet to capture imagination of Canadian providers and consumers.
It's such an interesting point, Zayna, because as we know, we're about to go into a political campaign with a variety of different, groups and parties. And this seems to be sort of the new thing, is like more facilities, more institutions like this. And I really like the way you said that you package it as like warehousing the seniors. And maybe this is not really listening to the patient. This is not listening to the end user, that they actually, in fact, don't want to be warehoused in these healthcare facilities.
Yeah, we all know that the political thing is ribbon cutting. With everybody loves bricks, but like we're just emancipating from that industrial era that all that matters is physical assets. We're in a digital world. And so, even the whole, ribbon cutting at hospitals where a big donor donates a wing or more beds or more MRI machines, the next generation philanthropists, that is not a legacy for them, and think about it conceptually. If demand for healthcare services is far, far exceeding the pace at which society is able to pay for them, the fallacy of linearly adding more beds, more buildings, more machines, more pills as services demand goes up, it'll never be enough. It'll never, ever be enough. And so by default, you're automatically, if you're in a very, physical asset orientation and making places for people to go to get care instead of letting them live their life in the home of their choice, it's like a tapeworm, and then by default, you're going to be rationing all the time. And so, that business model shift away from bricks and mortar and procedures, there's going to be a pull for it, but also a push, because the current way we do things is just, we cannot afford it. We simply cannot, and we never will be able to for at least 20 years, I think.
Yeah, so brilliantly said. And, I think you've alluded many times, and including in the book, this disequilibrium that's existing. And as we get into this aging place, and also with the acceleration of discovery and innovation with drugs and social with apps and digital therapeutics and all these things, there's going to be a tipping point where there's no longer an affordability. I mean, the percentage that this will cost, as you look at the GDP, it's not feasible. So I really love the fact that you can't solve that from here. We have to be in a completely different place to be thinking in a completely different paradigm in order for us to think about the new way we're going to be administering health.
I think a great parallel is this whole climate, situation we're in, where, we tried doing the, just do less. Let's get to pre-1992. I don't know what the number, levels. And Gates and others are like, there's no way you can do that, because that assumes you're just going to do what you do now, but do less. We have to start from zero as the target. Because when zero is the target, you actually can't just keep doing what you were doing, but do it less. You really have to rebase. And I think this crisis in healthcare of affordability, but also accessibility, the way we deliver things and pay for them does not serve for the people who need it the most. And so you can't quality improve your way through that. It's really a rebase.
So it's so interesting that you say that. I mean, you're really talking about going back to core basic principles. When we think about systems innovation thinking, this is exactly where we go. We go to basics. We start to rebuild with the Lego blocks, a completely new entity, and we start looking at bridging and incentivization. But in amidst all of that, we're also stuck in legacy, infrastructure, regulations, the way people do things, people's belief systems. How would you suggest that we make this level of disruption when people are not even ready for basic change within their own organizations?
Well, I mean, I think if you follow Christensen theory, that rarely does it come from the incumbents. I hate to admit it, but I kind of agree. And that's exactly what I see, that if you think, the stodgy 100-year-old institution that, was really created to eliminate innovation, right? It was created to ensure the status quo is here forever. They're going to self-destruct and blow that up on their own. It's just not going to happen. And it's not a criticism. It's not a mean thing. It's just how, again, I'll just do a metaphor, right? You think of a huge rainforest with those massive trees that have been there forever, right? They suck all the nutrients out of the ground. They provide all the cover. So any new thing that's trying to grow ain't going to get the light. But somehow some new thing comes and that old thing goes away. It doesn't happen all the time, but it does. So I think there's going to be new entrants. They're going to bring new methods, new models, and they have no baggage. They're not clinging to power from the past. They're not clinging to a mindset of the past. And when I say new entrants, I don't mean necessarily it's always going to be Apple and Google and some fast growing startup. It could be the postal service doing home care. It could be barber shops getting into preventative care for men. It could be the Bay becoming a place that people go to for mental health services. So let's think about, it could be some nonprofit. So I think that's going to be our bottom up. And then eventually, it'll just shift because the old way of doing things just won't serve, right? It's kind of like the emancipation we're having right now of fax machines. Like, my goodness, they're going to hang on for life. It's like the cockroach of healthcare. It'll never, ever die. But eventually there'll be a massive disadvantage of information flow, privacy, right? 30% of faxes actually go to the wrong place. So, hello, and just terrible quality because of, major. So eventually it won't be able to work, and then we'll switch over.
Beautiful. Yeah. So much there, so much crunchy stuff to double click on, but just say we started this conversation talking about the future of health at home. So again, the original hub was going somewhere, and the diagnostics and everything in a centralized place. Now it's this era of the great dispersion, right? So where do we already have things set up that can now start to accommodate all of these various things that are going on? So I'm thinking about the home. I'm thinking about people's vehicles. What's your thoughts about what the future of that looks like?
So there's two major mantras, if you will, or paradigm shifts. One way I like to say it is care follows the person, not the place. And for 150 years, we've obsessed about place. We have an entire ministry of government just for nursing homes. Like, really? We don't even have that for hospitals in Ontario. Mm-hmm. And so I think, so that's one. And then another version of that, which is like what a health system like Kaiser Permanente adopted, like, I think over 10 years ago, is just called Care Anywhere, right? So if you think of Care Anywhere, so it could be your car, it could be your workplace, it could be your kid's school. And care follows the person, not the place. That implies wherever that person is the place, right? Which again, it could be their home, it could be their car, it could be their, wherever they go to school or whatever. So I think when you start with that, every model of care anywhere that is possible, there are certain things that absolutely still need to be done in a facility, like maybe like brain surgery, certain types of imaging, but not many anymore. That's all becoming very, very small and very decentralized. But most could be done anywhere. And that is actually happening. If I add up pockets around the world, in theory, there is a fully decentralized, I'd say 70% of what's done in a clinic or a facility could be done at home. But then it's pockets. It's never one institution or one region or one geography that's doing all of it. But there are some that are working towards that. That's for sure.
So we're talking a lot now, obviously, about the acceleration of the digital revolution. Everything has become digitized. COVID has certainly propagated that. There's been a groundswell of momentum around it. How does this affect the seniors, people who want to live at home, who may not be digitally savvy, to be able to access the telehealth, who may be able to access some of these labs on a chip and know what to do and how to handle this? How are we going to increase people's tech savviness and digital literacy?
Yep. So I wouldn't assume, first of all, that seniors are not tech savvy or digital literate. So again, like everything, there's always a segmentation. There's a segment who, can, run circles around my digital skills. And there's a segment who it's just not going to work for, right? And I've seen it all, but guess what? We have the same in 20-year-olds. So to me, again, we just have to emancipate from that. Other digital access barriers, though, beyond literacy is for sure internet connectivity. So just access to bandwidth. And of course, ability to pay, whether that's for the data plan, for the hardware, or for the software. And then I think the last biggest access problem of all of them, where older adults are definitely disadvantaged, is just really terrible design. doesn't consider visual, language, cognitive ability, haptics, your physical ability, just poor user interface design and user experience design. So lab on a chip, like that example, or any of these, like, those could totally work even for a digitally unsavvy person, but the design of the experience, we always say should work for 8 to 80. If it works for an 8-year-old and an 80-year-old, it will work for everybody. And that capability of medical device manufacturers, pharma companies, and digital companies, they're still just not there yet. So I don't think that's the challenge. And I think the other thing about we live in a digital world and a lot of care will move to anywhere. That doesn't mean healthcare becomes dehumanizing. It doesn't mean digital takes over everything. It just means, my God, the friction of getting care gets taken away through digital, right? The things that don't need a human get done by a machine, so that these precious humans, of which there's a massive workforce shortage, the biggest ever, can spend their time doing the human part of care. So I actually think tech humanizes healthcare.
So what do you say in that regard? So well thought through, Zayna, about the shortage, right? We're already hearing all sorts of things about the diminishing population, not only in North America, but in China and Japan and all these sorts of things. What are we going to do to replace the much needed people, the PW, the folks who are actually helping people in their home, or in these, PSWs. So there's a shortage. There's not enough people. Do robotics come into play? Is this even part of the conversation? And where does that come in?
I think much like there's this rhetoric like, oh, we need to double the beds this, double the beds that, because we just project forward, assume everything we do is the same, and we're just going to add demand, and all of a sudden, we're going to ask for all this money. I think that's the step one of the workforce shortages, actually making sure people are only doing things that humans should be doing and taking away a lot of the low value add. I've heard numbers from 20 to 60% of a day of a nurse or PSW doing paperwork, right? Doing stuff that they should not be doing. So I think one, if we clean that up, I don't know how big of a crisis we would have, to be honest, on the shortage. Okay, if with what's left, we enable task shifting, we don't put people into cones of expertise, because that's not how the human body works. I think we can distribute capacity a lot better than we do today. If after that, we still don't have enough, and it's possible we won't, the three new resources come to bear that we have not tapped at all. One could be machines. There'll be life extension robots, digital companions that augment and extend. Absolutely. Japan's already been doing this for 25 years. The next will be the capacity of your community being tapped, grandkids on demand with an Uber app, and just a lot more the way humans used to live and work, that the village takes care of people. So that capacity was really tapped, I think, during COVID. So that will continue. And then the third, the most untapped renewable resource of healthcare, just like solar and wind is to fuel, is you and I, the patient. This completely untapped resource of power, of knowledge, of motivation. We have not designed care models to give power to the people who have the ultimate stake in their care. And we're just skimming the surface on that. So I don't feel like it's that much of a crisis if we believe in these new way of working. If we think we need to do things the same way we always have, of course we have a workforce crisis.
So let's get into that a little bit more. That solar wind, or that solar model of, the untapped with the healthcare consumer. Yeah. How can we change the perspective on how we're handling this? What does that new care model look like?
Again, I think you're not going to have the existing extremely paternalistic care providers, including my own industry, that have been doing it the same way, very provider-centered, initiate that. There's a little bit. I think our org has done a great job of initiating people-powered models of healthcare. It's going to come from others coming in who've been obsessed about the consumer from day one, and designing an experience, getting partnership with people who have access to patients. And then, patients can't go back after that type of an experience. I think that's going to force this. And so that'll be companies like Apple and Google and Walmart and Amazon, Samsung, and then even some other players like Lululemon. And, I think Home Depot is going to get in this space. Best Buy, they predict their elder care portfolio will be their biggest driver of revenue before electronics. right?
And so let's get
So
into that, because it was funny. I interviewed somebody recently from Best Buy Canada and Best Buy Health Canada. And what an interesting model. I'd love you to speak a little bit about that, where their Geek Squad, who've
yep.
traditionally come into your house to fix your TV or set up your new computer, can now be positively trained in managing some certain questions or whatever, and helping to sort of navigate real time and going from house to house. That's an interesting model. But you also brought up this idea of Uber Eats and Dashboard and the Amazon, drivers. What could this look like in the future?
I mean, look, I'll give a great example. And by the way, I love what Best Buy is doing. We work with Sarah and her team, and we've got a lot of time for Geek Squad, and we're using it with a lot of our patients. The other day we were, up north at our cottage, and one of the kids, jumped off the dock, landed on her toe, like her whole body, and the nail kind of popped off, and the toe was like swelling and swelling. We're in the middle of nowhere. It's a weekend, of course. That's when kids always get hurt, when nothing's open, because our healthcare works on a 9-to-5 model. And so then we had to drive back to the city. She's screaming in pain. I don't know if it's infected. I don't know if it's broken. Of course, you call Ontario Telehealth, or, you try the system, and they're like, just go to the ER. It's like, well, can't you just do something? It's not like this has never happened before. Anyway, while we're driving in the car, I'm like, children, when your children this happens to them, this is what's going to happen. They're going to right away get some kind of a digital assistant, to come, maybe a teleportation of them, look at the wound, ask a few diagnostic questions, and confirm right away if it's broken or suspected broken, infected or suspected infected. You'll have an easy bake oven in your kitchen that will print your meds. It'll 3D print your meds. There goes the whole pharmacy industry. And if it's broken, you'll do an X-ray probably off your phone. You'll have some way to do it, or it'll drone in. And you'll 3D print your cast. And if you want your cast to be blinged out, or zebra pattern, or pink, or yellow, or change it every day with your outfit, you can do that. It's not going to be a boring caster, so that's kind of what the new model will be. And again, what I just described is happening in pockets. It's just not the standard of care.
We've already seen Google has released that, Derm Assist or something like this, where you can actually take a picture of your skin and start, they're slowly starting to do this. But every time they do, there's all kinds of controversy. And what does this mean? And what's my privacy and all these other things? So how are we handling this dichotomy in society where, again, not bringing politics, but, I have never seen since COVID so many different versions of reality, and every one of them person believes it to be true.
Yeah.
So how do we handle this disparity in the thinking? Is this a good thing, or is this a terrible thing for society?
Well, I mean, I think the thinking is a different thing, because any new thing, right away, everyone will tell you why it's wrong and no, right? Virtual care had that problem for the longest time, right? So I don't take any, to me, that's the human reaction, everything. Like if you look at the history, the telephone, the fax machine, everyone's like, this is the end of life because we did this technology, trains. So that I don't care about, but I think it's more of, the answer is evidence. I think we do have amazing scientific methodologies. We've got an agreed upon framework called science and peer review, and that does work. And I think that's why a lot of, I think there's 350,000 digital health apps now. Like the barriers to entry are nothing. And, you'll never get 350,000 new pharma products or new, medical device products. There's probably 50 pharma and maybe 2,000 medical device a year because they're very capital intensive. But anyway, I think evidence will weed out a lot of the crap, and then what you've got left is good. So I think that's an equalizer. I think the other is, you just have to understand the pattern of exponential technologies. There's a mucky period where it doesn't work the first time, where the driverless car doesn't know how to make the choice of, the kid crossing the street versus, the grandma, whatever, and if you can just wade through that and just know that's a normal part of the thing, then you come out the other end, and these are on the exponential curve. So our brain is projecting linearly a phenomenon that's happening exponentially. So it'll be here really soon. And again, just like a differential diagnosis from an AI for a basic urgent care thing, broken finger, ear infection, That's already happening in a lot of parts of the world.
Yeah.
Just not here in Canada, because, we tend to be 15 years behind everybody else.
And that's going to be part of our discussion in a few minutes. We'll get into that. Pharmaceutical industry has been a mainstay in the way, part of our GDP. They have incredible lobby groups. They've done all kinds of great things. And certainly it depends on what perspective, if they did a great thing or not thing for COVID, acceleration of, everything from the discovery, regulation, dissemination, supply chain. What do we learn from that? And more importantly, what is going to be the future of the pharmaceutical industry?
I mean, I think first and foremost, reminder, what does technology do? And pharmaceuticals are just a technology, right? They're just they've got a physical form and they might affect your metabolism, but they're just a technology. And so technology replaces capital or labor. It allows existing capital or labor assets to be a lot more productive because it could replace them completely or just, augment them. So, wow, does taking a pill for, say, cystic fibrosis, what an amazing technology, because it replaces thousands and thousands of hours of other ways to manage, let's say, the disease, as an example, or say an infection, right? What an antibiotic can do. So amazing technology and but very science-based, as you know, and a lot of clinical risk, and then of course market risk. So I think coming out of COVID, we've done a lot of analysis of kind of what happened, of accelerating, the development cycles. It just showed that it actually is possible, both for the manufacturers as well as the regulators and the adopters to move at a very different speed, because they're all aligned around, if this was my mother or my daughter or my sister, I would want this to work this fast. And then I think in general, if you take the entire R&D through to marketing pipeline of pharma, every piece of that is now up for grabs to be redone, as we've seen. Clinical trials, discovery, the big, huge thing recently with Google DeepMind on protein folding. So I think the entire business model. So again, when tech comes in and replaces capital and labor, of course, then the economics change, then the business model changes. So pharma's business model is completely up for grabs across the entire value chain. And so I think, our chirping about big bad pharma and their cost, I think will start to go away. And the pharma that wants to hang on to all that money and power will not be in business.
So we've actually gone from an era, quite frankly, 20, 30, 40 years ago, where they went for the big, the big clincher drugs, the ones that, would take over, and they were all empowering and they were making all kinds of money on that, to a place where basically there's a medication for almost everything.
Yeah.
So now the next echelon is the rare diseases, the oncologics, things like, the immunotherapeutics and all these complicated products. And now everything is getting stacked and double stacked, and there's biomarkers and diagnostics, and the price tag just starts to, get to be an insurmountable amount. Is this worth this all? Or are we just going to get into a place where there's going to be a digital therapeutic or an app, or, what does this look like, and how are we going to afford this?
Yeah. Again, I wouldn't accept the cost thing as a given, that technology is going to keep doing its thing, but somehow pharma's business model is going to stay the same. It's not going to happen. So as we move from, blockbuster type drugs to designer drugs, N of one medicine, whatever you want to call it, the business model has to change too, which means the economics of development. And that's exactly what happened with Moderna, right? This new platform technology allowed to take, 12 years out of the R&D cycle. 12 years, like that changes the whole economics, right? Then more innovation around the adjuvant, around the delivery system, that made the thing more powerful. And then a ton of innovation on distribution. So I don't think we have to accept that, N of one type things or smaller, population to amortize the cost necessarily means higher price tag. I think that's what innovation is break those paradigms, and whoever does is going to win. And I mean, to me, a great parallel is look at NASA having to spend 15, 20, 30 years to get a rocket to space, billions of dollars. A scrappy little entrepreneur who knew nothing about space did it at a fraction of the cost, like a true fraction of the cost, and is now providing that infrastructure to the incumbent who's been doing this, all the time. I think those types of trade-offs will happen. But I think your other point about, can digital therapeutics replace what pharma traditionally did? Again, yes, in some cases, much like pharma replaced surgery, in a lot of cases, or pharma replaced hundreds of hours of psychotherapy, right? Because it was the better path. And so I think, again, an evidence-based approach will tell you which tool in the toolbox and which combination gets you where you need to get to. And there's going to be change for everybody as a result of that.
The patient has, we've always heard the word patient centricity, multiple different versions of it and definitions of what the hell it means. But here's really the clincher is, are we going to see a future where everything kind of revolves, where you actually can do crowdsourcing? Patients of similar conditions or situations or social economic status get together to start planning their trials or funding their trials.
Yeah, and that's already happening.
Their insurance. What does that look like?
Yeah. So again, I don't like patient-centered, because patient-centered still is us paternalistic providers, now at least involving you a little bit in the process of whatever, and so much like in care delivery, care follows the person now and not the place, because the place obsesses with the power and the money staying with the provider. The barriers to entry to participate in generating new products, services, and policies are gone, right? It used to be relegated only to those few players, right? It was the same 15 pharma companies for hundreds of years, the same device companies, nobody in digital health, because we needed to count on Orion and Cerner and, IBM. Now anyone can, including citizens. And so citizen hackers, patientpreneurs, whatever you want to call them, both as individual, saying, look, I live with this disease. Nobody knows it better than me. I'm going to make a solution. And I have a whole catalog of those, or peer-to-peer. So Susanna Fox used to be the head of innovation at CMS, Medicare in the US. So think about, this is like a $1.2 trillion healthcare system. You're the head of innovation. You think that's kind of the dream job for impact in the world. Ditched all that to go start a new movement of peer-to-peer healthcare, because the power of tapping each other is huge. And again, before it was patients like me, they were the only player in town doing that, in a web-based friction, ways to connect are all gone. And the people of the biggest stake in their health will organize themselves. Absolutely. Not for everything, but it's another new entrant on the scene, right? Just like Apple and, Home Depot will be new entrants.
Yeah, I love the idea of the C2C that we're now starting to see. So it's very, very intriguing. Same as all the discussion that we're having about this burgeoning of fintech, cryptocurrency, blockchain, NFTs, so non-fungible tokens, and how all of this may or may not fare with how people pay for drugs or not. And, I'm just curious, is this part of the ecosystem or some of the things that you're considering and the impact on healthcare?
Absolutely. So I think on two fronts. One is on just data liquidity and data flow. So that, if care follows the person, not the place, then all the data flows to and through the person who the data is about. It doesn't get stuck in prisons in some, medical record that you need 7 passwords to access. And, so there are places like in Switzerland and others that have already been building these, basically like a co-op bank owned by the members that stores your health data on a blockchain platform, of course. So I think, those types of things to allow, digital identity and security and control of access to one's data is a lot easier in a distributed system. I think on payment models, again, amazing financial products coming that, patients can run their own generic drug companies. They can, they can build their own insurance program to buy their own drugs. Forget the middleman. Patients can be part of a platform where all their data patterns, their searches on Google, their purchasing, their Fitbit, they can sell to a platform on the blockchain. And then every time a pharma company interrogates that data to design a better drug, the patient gets paid, right? So those already exist. Again, they're just not the everyday, but they will become just normal.
I've heard that there's just gigantic waste in the healthcare system with drugs that are prescribed. People take them for a while, they don't adhere to them, they get wasted and just dumped somewhere. Could you ever see, I know there's going to be tons of regulatory and issues and all sorts of things with this, but a platform where people are trading the drugs, they're going through a physician to sort of retrade or get something. I mean, can that actually reduce waste in the healthcare system?
I mean, I think that's one type of waste. I don't think that's that big of a deal, but that is already happening. If you go on Kijiji or Facebook Marketplace, you can buy drugs that are very, very expensive that somebody tried, didn't use, and they sell them. So that's already kind of happening. I think the bigger waste is the fact that the stuff gets prescribed and there's no accountability to the prescriber on, did it work? Did the person, match, implement the protocol or whatever? And then, or the other waste, there's a whole article this weekend about just unnecessary surgery. I mean, look at the labor and capital and human cost of surgery. So I think, there's a whole movement called Choosing Wisely, which is about all modalities, not just drugs, that you literally are unnecessary, duplicative, wasteful, or actually harmful and wrong. And that's about 30 to 40% of all of healthcare. So you tell me if you're running a company that was broke and they said, oh, but we're running at a 30 to 40% inefficiency. You wouldn't tolerate it, right? It's like your kid asking you for money every week so they can go keep buying McDonald's, and it's like, no, I'm not going to give you any more money if you're going to waste it on that, right? So I think that's a massive opportunity. And again, when we run an information-based health system, that waste won't be able to hide anymore.
Yeah, absolutely. So we've talked a lot around, the way we're going to be paying for these things, what this is going to look like. What else are we thinking about around, smart algorithms, AI? I'm even thinking about, virtual reality, metaverse, AR. Where is this going to play? And more specifically into the lives of some of, our seniors and aging, moving into the aging part of your life.
Yep. So at Singularity, we track around a dozen exponentials in healthcare. So these are the emerging technologies, and you listed a few of them. And to me, I would distinguish that clearly from just everyday old boring digital. Digital just digitizes a bunch of manual and analog things that didn't used to be digital before. That's virtual care, that's documentation. Emerging technologies actually allow you to change the care model fundamentally, right? The experience between the clinician and the patient, how information flows, what modality. So that's why we have Singularity. I mean, that's why we look at these, because they're game changers, on many levels, but they're all on their own S curves. They're all on their own development pathways. But particularly for older adults, few key technologies that are going to be a big deal for sure. Voice is the easiest, most natural interface. So an Alexa type interface. No screens, no buttons, no passwords, conversation humans have been doing as a species millions of years longer than language and visual as a way to communicate. So it's just in our biology to speak through voice. And then, really amazing NLP, like Microsoft just bought a natural language processing company. So I think voice will be a great interface for everything as the first interface. For all of us, by the way, phones and apps will go away very soon, but for older adults, for sure. I think sensors for remote monitoring, safety, independence, checking the door, checking the floors, checking the bed, checking your toilet, all that stuff in a non-Big Brother way. And I think AI will be more for predictive health. So instead of waiting for symptomology and problem and doing sick care, AI crawling and mining all the data from your voice and your sensors to be able to predict grandma's about to have a hypoglycemic episode or a schizophrenic episode or fall because her gait has started to, be a different way. That's going to be, I think, a big game changer.
Yeah, that's beautiful. I absolutely love that. In this whole realm of predictive analytics and planning and preparing, so getting into a wellness mentality and mindset as opposed to the sick care that we have actually inherited, is I'm thinking about CRISPR, I'm thinking about genomics, I'm even thinking about the point of regulating so that when somebody is born, their genome is provided, and then suddenly it becomes an N=1 of planning and preparing and always comparing to your own self as opposed to some other population management database. What does that look like?
Yeah. So, I mean, the quantified self, if you want to call that. So I think you've thread a few concepts. Let's just unpack a little bit. So this shift from sick care or reactive care, which is what basically the paradigm has been, and we've built all of our institutions around, again, why does the Canada Health Act only legally pay for doctors and hospitals? Is because we had a sick care paradigm, right? And so proactive care, health, predict, and preventative, and then predictive is just the next level. So let's get into that one. So predictive isn't preventative, right? Preventative is PSA campaigns and, food guide, and, predictive is I'm going to catch stuff way, way before a risk factor appears, let alone a sick symptom, and nip it in the bud. And some of that will be biological prediction around, your signature of your DNA or whatever, your epigenetics, and, some molecular surgery gets done at birth or whenever. And then others are, more of, oh, wow, the last 5 times it rained, you had a blood pressure problem. It's going to rain tomorrow, so let's up the dose, or, so I think, it's that whole gamut. So whereas your input, your data input that feeds the AI to predict could be biological data, it could be physical movement data, and it could be, your sociograph, like your patterns of what you're doing every day in your life.
Data is so important. And we heard the old cliche, and I'm tired of it. It's the new gold, but it is. And the fact is, with all of this, it really does, from a bioethical standpoint, ask the question, our standard version of what privacy and surveillance and all these other things, is there a requirement to change the definition or the interpretation of what that means, just in light of data is going to be everywhere? And really, I guess a thought experiment here, Zayna, is what if we considered the fact that everybody's data is available for everybody to look at? What would that look and feel like?
I mean, we'll look at, I wonder what do we mean by that? And so in most of these models and new businesses that are emerging that are running on data as the business, not the process of getting the data. So for example, you can now do your whole genome sequence, which 15 years ago cost $3 billion and took 30 years. Now on the market, the cheapest I've seen is $200 for a whole genome. But again, even that, the public sector won't finance at this point. That's because you're paying for the cost of swabbing your cheek, getting the sample, mailing it, putting on the Illumina sequenome, and then getting your results and getting them interpreted. There are now businesses that'll do that for free, because there's no business model on the process of a diagnostic to make your genome, and their business models on the data they get. So your data being available to everybody absolutely is happening, but fully anonymized. And I think some say you can't anonymize anything anymore. Others think you can. So I don't know. I'm not an expert. So I don't think that's as much of a challenge. And of course, though, you need to have the right to not participate in that, right? So either it's by default you participate in, i.e. I give my data to science, or it's automatic you do and you have to opt out. There are jurisdictions who are way ahead on this dystopian view than we are, right? China. 1 in every 2 newborns gets whole genome sequenced automatically at birth. That they did that policy in 1 year. In Canada, that would be 30 years of debate. Okay.
Yeah.
So, and the surveillance economy with COVID. So there are places where society, whether they're voluntold or they choose to embrace, like they're going to be ahead. And I think that's going to create a very different inequity across jurisdictions.
It's going to be a very interesting question. And I know this is a very political one, but it is worth at least exploring, is that in the next, we're obviously moving towards, if not already in a Cold War with China. And so there's a battle between powers and currencies and political views and what have you. Is there going to be a system that might be better prepared for this complete revolution in data, in healthcare? And is there components of the regulation and legislation that's going to make one better than the other? And the other thing, added to that, Zayna, is the decentralized, autonomous organizations, and the idea of potentially replacing some of these governments with something that's a lot more unbiased, and it's more of a contractual sort of smart contract. So I'm actually just curious about the things that we've built into our basic constitution. is that going to be putting us at a disadvantage
Huge.
compared to some others?
Yeah, I think there's two versions of the answer to that. One is absolutely, because we didn't get ahead of the future and stuck to the past, we will be at a disadvantage in modernizing our healthcare systems compared to countries like Estonia, right? Or to some extent, Taiwan, et cetera. And that's just a poor loss for our patients and providers. And also, we have very limited tax money to go around. And so, what a poor use of money to keep, feeding the old beast. So that's a big disadvantage. I think the next level, though, is countries that they're playing in a different game, right? So if imagine a country like China, like they can do embryonic edits right now they can, choose to change the embryo so that the child isn't, have a major disability or something, but they can now start to select for traits of sports dominance, music dominance, rocket scientists, women, men, eye color, and the rest of the world isn't doing that. So you can now build a species that is of an advantage. And like those types of ethical conversations, we are not yet having as a global species. So that's coming.
It's a very interesting, and I think that's the one that's going to be very crunchy, and it's going to cause a lot of, political divide on it. What's next for SE Health? And I'm just curious, we're looking right now at the book, The Future of Aging. So tell us, what is the next big thing? What are you guys working on?
I mean, I think there's quite a bit going on, and it's not just my team, but I kind of split it into maybe three fronts. On our business of caring, like doing high volume, largely government funded care of older adults in their homes. It's so ripe for so much change around the care model, the payment model, technology. There's been a lot of moves in that space in the US recently in home care, hospital to home, primary care at home, and nursing home at home. All that is coming to our sector to kind of move the location of setting to the home space. So that's kind of the traditional care, and that's already enough to keep everybody very busy. I think the second is in some of the adjacent spaces we're in, like our Eliz caregiving platform. We're seeing an explosion of demand from employers who have workers who are taking care of an older family at home. So it used to be the caregiver at work had a child at home, right? That a baby. Now it's your mom and dad, and so products, services, solutions to help the employer take care of their employees who are caregivers. So that's just coming to Canada. That's already all over the US. And then the third is us moving more into upstream drivers of health as a social impact engine. So sure, we can do great care, but that'll never be enough, right? People will keep getting sick. So we have a big focus on housing, affordable housing. So that's a new business line for St. Eliz, First Nations health and capacity building, taking that to the next level. And we have the first ever hospice for homeless people in Canada. We've now opened our second one. So just these kind of new things that work on social causes. So that's a pretty big portfolio for St. Elizabeth Healthcare.
Oh, it's absolutely astounding. And, certainly we could talk a little bit about all the partnerships, certainly like even just thinking about the ecosystem in Canada. You've been doing work with Google Canada and Best Buy Health. We just talked about, you've done work with RBC on their, like you said, your Care Easy app, and also even with Maple. So for other people wanting to partner, what are some of the ideas about how they could partner with you?
I think if you're in any kind of a, public good organization, whether you're for profit or nonprofit, partnership, if you want to solve messy problems left to solve in the world, and I think most of us do, we all want to live for purpose and work for purpose, you got to do that through partnerships. There's just no way you'll be able to do that in the four walls. So we've built, I think, a pretty good capability around partnerships. If anyone specifically wants to kind of get in with our space and futures, our website, I think it's futures.sehc.com. We can put it in the chat, but it's not hard to find. You can get it through my Twitter handle. It's there. We've got an intake form there. That's the easiest way to get to us.
Absolutely. And for people who are listening, we will be leaving all of Zayna's contact information. If you're interested, personally, I could probably speak for hours with you. This is an outstanding conversation. There's so many important pieces here. And I love, love, love the work that you guys are doing. For anybody who enjoyed this conversation, we also encourage you to check out impetusdigital.com. These are the kinds of conversations that we savor in our asynchronous and synchronous platform, where people are moving the needle ahead on these agendas, these important crunchy issues, pushing the things forward. So we're going beyond the pill and we're reinventing the pharmaceutical business model. So please check that out. We'd love to do some work with you. Thank you so much, Zayna, for a fabulous conversation. And we want to thank everybody for their time and wish everybody a great day.